Okay, wonderful. So, good afternoon, everyone. It's a pleasure to welcome you all today at our PEM update session. We are honored to have with us Dr. Umana. He's a consultant in emergency medicine at the Mater University Hospital in Dublin. Dr. Umana brings a rich blend of clinical expertise and research excellence with a PhD from the Wellcome Wolfson Institute at Queen's University, Belfast. His work leading the Febrile Infant Diagnostic Assessment and Outcome, a study across 35 centers in the UK and Ireland, is truly impressive. We're excited to hear his insights today, and especially as he continues to contribute to VTE management, resuscitation, and quality improvement in acute care. So please join us in giving a warm welcome to Dr. Umana. And Dr. Umana, the floor is yours.
Thank you very much. I'm delighted to be here. Um, I'll try and make I'll try and make my presentation as brief as possible. And just to kind of explain what the FIDO study has done in terms of moving practice forward, particularly for us in UK and Ireland, where the evidence wasn't as rich, if I might say so. Um, okay. So I have no conflicts of interest to declare, and after this presentation, I'll be happy to take on any kind of questions. Um, so these are all the amazing people who contributed to the research to make it a possibility because this was done across 35 centers in UK and Ireland, which each team getting a bit of a certificate if they recruited more patients as well. So we had a lot of games and fun in terms of making the study inclusive, exciting, and feasible for a lot of sites. Why febrile infants? We know that they present regularly to emergency departments and around 1 to
Sorry, Dr.
4%.
Umana, if you can
Yes.
share your presentation because we can't see it.
Oh, sorry. I thought you were able to see that. Um, oh, sorry. Can you see it now?
I think, yeah, now it's visible. Thank you.
Oh, sorry about that.
No, it's okay.
So I just started off saying there's no conflicts of interest to declare, and this was the picture of all the people who, well, there's more than this. Couldn't fit the whole 35 sites into the slide, but that's a picture of all those who contributed to the study. Um, like I was saying, why football infants? Because they are a challenging group to manage, and I think when they come in with their parents very worried or concerned, we also get very worried and concerned as well. So we know that around 1 to 4% within the evidence, 1 to 4% of febrile infants will get invasive bacterial infection, which we'll define as bacteremia meningitis. And this is really important because evidence has moved away from saying serious bacterial infection, where we combined bacteremia, meningitis, and urinary tract infection, which we know urinary tract infection in this cohort is around 5 to 20% and very variable. So, and then the remainder of those infants who come with a fever, likely source will also be of a viral origin as well. So, if you look at the trajectory of the course in terms of managing or the epidemiology in terms of febrile infants and when they present, what are the causative agents, we see here that kind of pre-2000s, it was Listeria, Streptococcus pneumoniae, as well as E. coli and Haemophilus influenza. But obviously, with the advent of vaccines, maternal screening, and public health measures, that has kind of come down to like E. coli, GBS, and Staph aureus, which has also been found in other jurisdictions such as the US and Europe. But one thing I want to really echo home, because I haven't worked in Saudi, I haven't worked in Saudi Arabia before, or kind of the Gulf countries, so I can't really, I don't know what this would look like. For example, if I were to make this kind of graph or this kind of map to see what's the current practice. For example, in the UK, we do a lot of auxiliary temperature, whereas in the US and in Spain, they would do a lot of rectal, and they would swear, they would say, this is the way we do it. You shouldn't be doing auxiliary, you shouldn't be doing forehead or anything like that. For example, in Spain, I know my Spanish colleagues would prefer to, if a child comes in, if the infant comes in and they have a bit of rhinorrhea, cough, whereas that they would define that infant as having a source. So therefore, they would not work up that infant. Uh, you know, in the UK and Ireland, we would do clean cat urine, whereas in US and Spain, they do catheter urine, and so forth. So I think when you look at the management of febrile infants or trying to apply any clinical decision aid, you have to take it in the context of what your practice is like. And a lot of the studies that have been done in US and in Europe would have used particular criteria or particular types of practice. So when you're trying to apply to your own, you have to decide like, okay, this is the limitations, or this is how you have your practice within your own setting. And I think that was very important, and that's why the FIDO study was really important for us to do it, to understand what our population was, what our practice was, and what this clinical decision aids would do within our own setting. And we know that clinical decision aids are quite nice, and they usually use a range of criteria to define an infant as low risk, meaning that they might not need antibiotics or lumbar puncture, right? Or their management will differ from those who are determined to be high risk, which would likely be admission, antibiotics, and a lumbar puncture. So we usually use age, appearance, urinalysis, and biomarkers, which the most common ones we have are absolute neutrophil count, which is ANC, and C-reactive protein. However, PCT, which is procalcitonin, is commonly being used in a lot of jurisdictions, like some in Europe and in the US, um, but it's not readily available worldwide. So that might limit using certain clinical decision aids, such as PCAN or step by step, which use PCT, which can be readily applied so easily within our own setting in UK and Ireland. This is just a geographical map just to see the spread. This was part of one of the work from my PhD where we did a scoping review of all clinical decision aids. And as you can see there, that the studies done for clinical decision aids on febrile infants, majority of them have been produced in North America, like in the US in particular, with very few spread across Europe, done particularly in Spain and Switzerland, and then a few down in Asia in Singapore and Taiwan. So I think this is why we also have to be cautious about when we see evidence, and want to apply to our own jurisdiction, we have to know what their own practice is like before we do that. I've already mentioned the step by step, the PCARN, and recently in 2021, we had the American Academy of Pediatrics guidance on febrile infants, which gave us the option to use either CRP or PCT. A less common one known, I think, is the Aronson Febrile Infant Decision Tool. This one only uses the ANC as a biomarker, and it's actually important. The reason we chose to look at this was because it didn't have CRP or PCT, so it can be more readily applied to different jurisdictions. In UK and Ireland, in the UK in particular, the two main CDAs that are being used is the fever under 5 NICE criteria, which says over a month, well appearing, and having WISA count between 5 to 15 will be classified as low risk. And you have the BSAC, with the British Society of Antimicrobial Chemotherapy guidance, which says that over a month, well appearing, normal urinalysis, normal CRP, and ANC would be defined as low risk. So why are we doing this? Why is it important? We know we want to improve antimicrobial stewardship to prevent, why give antimicrobials if we can avoid them, because they are not benign, particularly in that cohort. I mean, evidence has shown that they can increase things like incidence of obesity. They can cause change in the gut microbiome. So if we can avoid them and use them effectively, then I think this can help us as well. And then parental confidence, in that when we're using clinical decision aids along with our clinical judgment, then that would help in terms of increasing parental confidence that we know we are managing their children well. And healthcare costs has increased, and we want to try and decrease that, and also admission rates, and reducing the amount of LPs that we're doing as well, which are necessary. I'll just skip that. Just to say a word on communication, in that part of the FIDO study, we had looked at communication and how we communicate to parents about the investigations we're doing. How do clinicians inform parents about it? Do they use raw numbers? Do they use those kind of examples of things to reason with parents, and at what time is this information important for the parent. So this this model, you can see that communication, information provision, and strategy decision making is quite important because, in as much as you understand the evidence, we know that the EBM pillars are the current evidence, the practice, and the patient's wishes as well. So we need to take that into account. So in the FIDO study, what we did was we evaluated the diagnostic performance of the main four CDAs, which was the Arensons, the NICE, the BSAC, and the AAP with CRP. And then we also did a sub-study where we looked at the AAP with CDA with CRP versus PCT. We also wanted to know what was the current management. Um, we also want to know what the current management was, and we also, in this slide, in this presentation, I'll show you about the diagnostic accuracy of CRP and PCT, but I think I'll just leave that. But just want to know the current management. We want to assess the clinical and laboratory predictors of IBI and in infants 90 days and under. And then the last bit is just an extra that I've thrown in is just to explore. We did a qualitative study where we explored the clinicians' views on how best to communicate different treatment strategies, including risk and benefits, to parents as well. So this study was a multicenter observational prospective cohort study across 35 sites in UK and Ireland, used the Perukid network, which I'm very grateful for. So it's done from July 2022 to August 2023. And inclusion criteria was very broad compared to a lot of the other studies that were done. And I've been asked about this multiple times, that why did we just say under 90 days? Because AAP would say under 60. In the US, they would usually they would, they would they would work up infants only up to under 60 days, whereas we would do up to 90. And part of this is that we had done an earlier sub-study looking at some of our data sets, saying that the risk of IBI in our own cohorts up until between 60 and 90 days was still above 1%, 1.5%, if I'm not mistaken. So for us, I think NICE already sets it down that we would investigate or manage these infants up to 90 days of age. And the other thing as well was we knew that we as in UK and Ireland, we don't do rectal temperatures essentially frequently, and there was auxiliary temperatures. So I wanted to include as many infants as possible. So that's the decision where we said it was going to be measured temperature by any thermometer within 24 hours of presentation. All infants had routine clinical care. We didn't influence the way the sites practiced. And then 1 ml of blood, where possible, was taken for procalcitonin analysis. And this was based on our PPI engagement, where we spoke to parents and said, okay, fine, we want to do the study. I want to take blood. Should we take bloods outside routine phlebotomy? And they said no, they prefer it to be taken during routine phlebotomy, and that was probably the only way. And so what happened was that when bloods were taken, priority was always towards routine blood, such as your full blood count and your CRP and renal function, so that if the sample was enough for those three, it would be done. If an extra sample was taken and was able to be saved, then that would be saved for PCT. So that led to the fact that that's why we did not have a lot of infants with PCT done. We define IBI as a single growth of bacterial organism in the blood and CSF. And then again, we said the main outcome we looked at here was the diagnostic performance of the CDAs. We also wanted to know the kind of organisms that we had in terms of IBI, and we also wanted to know about their mean cost, and we also wanted to find out about their current management as well. For the qualitative study, we created clinician and parent questionnaires and developed a topic guide to help us do the interviews. The interviews were conducted remotely through Zoom and telephone calls. And then we used the in vivo software to analyze the thematic analysis. So this is just a schema showing all the sites that we had undertaken the studies in. Like I said, 35 sites across UK and Ireland, which was great, and a kind of a good geographical spread and representation. So we recruited we recruited over over 2,000 infants, but when we had put in our exclusion criteria, which was things like if they didn't consent to the study or they had incomplete data, we that was brought down to about 1,821 infants over a 13-month period. The median age was 46, 61% were males, 53% presented within 6 hours of onset of fever, 58 were deemed unwell appearing. And when I say unwell appearing, that means the after the clinician's global assessment, and along with their vital signs, the clinician they were determined to be unwell appearing, and that's 58%. 67% were seen by senior clinician, and that is anybody who was at the level of a registrar, fellow, or consultant. And then we can see that our IBI rate was 3.7, which was in line with kind of what is in the literature as well. When we broke down the 67 infants that had IBI, E. coli was the most predominant, followed by GBS and Staph aureus, which again, kind of when I spoke earlier, is in keeping with was in the evidence as well, showing that shift away from Listeria monocytogenes, from Haemophilus influenza and streptococcus pneumonia as well. And also get some of the questions about the kind of antibiotic administrations that we in the future we might need to start thinking about if those bacteria are not as endemic as they were before. So not all infants had blood tests because again we didn't force sites to practice in a particular way. So 89 had blood tests, and with the blood tests, the variation ranging between 76 in some sites, 76% having blood tests, to some sites having blood tests for all. And then urine testing was 81%. Again, variation between sites was between 62 to 100%. And then CSF testing, you can see that's about half the number of infants in our cohorts, and that ranged between 18% to 100%. Respiratory viral testing, again, this was kind of a post-COVID study. So you can see when we compared it to previous kind of pilot studies, we saw that, respiratory viral testing has really increased from, anywhere below 40% to now up to 77%, again, seeing that range. So the median length of stay in the hospital was 2 days, while the ED length of stay was about 4 hours. 14% were discharged directly from the emergency department. 9 were admitted and ambulated, meaning that they were admitted to a hospital, and either that day or the subsequent day, they would have been that day or subsequent day, they would be discharged and brought back on a daily basis, anywhere around maybe 3 to 5 days, and they would get either the antibiotics or have their bloods repeated or just have a reassessment. Okay, some were admitted and just observed, with only I think less than half of that population or cohort ended up having antibiotics. All right, and then about 68 were admitted with antibiotic administration. Excuse me. So we looked at clinical predictors for IBI after doing a multivariable regression analysis, and we found that if the clinician opinion of IBI was likely and they had no unwell contacts, no rash, and no coryza or cough, that they had a higher likelihood of higher odds of having an IBI. So that was actually quite interesting. For the main kind of outcome we looked at here is that this is the table which is in the publication that we did in eClinical Medicine, showing the performance of the clinical decision aids, in that the NICE fever under 5 clinical decision aid had a sensitivity of 93 and a specificity of 0.27. So essentially, it was able to identify a low risk score around 27%. Now, but it misclassified 5 infants as low risk. For the BSAC and AAP, they both had 99% sensitivity, and again, their specificity was around 20 to 23%, misclassifying only 1 infant, meaning that the misclassification rate was around 0.3%. And this would be in line with some of like the AAP or step by step, which was quite good. However, this specificity is quite low. The key thing with BSAC and AAP with CRP was that the infants that were misclassified were those who were over between 29 to 60 days of age, but they presented within 6 hours of fever onset. So it means when you're applying some of these rules, you just have to think about those infants as well, in that you might need a longer period of observation if you're using this to work, if you're using this for infants who are presenting within 6 hours of fever onset. And as you can see earlier in the slide that, over 50% were presenting within 6 hours of fever onset. And that's why I think this study is important for UK and Ireland, but I think it's something that will need to be replicated in your own institution or a country as a whole to really understand the demographics and epidemiology and management of these infants so that when you are applying this, you now understand what are the limitations of this clinical decision aids as well. For NICE and RNC, they misclassified, like I said, 5 and 7. They had the sensitivities were not that great, but the specificities were much better than the BSAC and AAP. Now, the reason for their misclassification was more or less that they didn't use CRP, and that was, I think, or they didn't use criteria such as unwell or well appearing. So what happens is that majority of the ones that are misclassified either had higher CRPs or for RNC were unwell appearing. So it does show the limitations when you're using these clinical decision aids. Okay. When we look at cost, the mean cost for the clinical decision aids, if you use a treat-all approach, per infant. You see that was 1,537. So that cost has actually kind of increased from earlier studies that have been done, which showed it was initially 1,000 if you did everything, £1,000. But we can see that the BSAC and AAP are not doing too bad. They're still better than the treat-all approach with a mean difference between, 2 to 300. Whereas the Aronson and the NICE were the cheapest, of them. So I think what this does for us is helping us understand the um, the cost implications of implementing the CDAs and then understanding their diagnostic performance. So as an institution, as a hospital, as a department, you can now decide, okay, if we go with RNs and we know that the issue is we don't want to meet, if they're unwell appearing, we can adjust it to say, okay, fine, this is how we're going to implement it, but we know it to be cheaper. But, on the safer side, you can say, you know what, we'll use the AAP with CRP because we know the likelihood of missing an infant is very low. Only those who are present within 6 hours of fever onset, we just have to be careful, cautious about. But that's what this information has done for us. When we looked at those cohorts of patients that had PCT available, that was 466. We saw that there was no difference statistically, or there was no significant difference between the sensitivities and specificities. However, obviously, it's a smaller cohort compared to the larger cohort. And then their low risk cohorts was around 15% each. So the only difference that we saw here was just that the mean cost per patient was higher for the PCT group, which we do know that PCT is much more expensive than CRP-based CDAs. Okay. Um, so what did we find when we did the qualitative study? What the parents, particularly in the UK and Irish setting, really want. They usually had confidence in treating clinician, and the what parents, and this is the framework that was developed from the understanding of what parents wanted. Um, they had a high trust for clinicians, and what they said, they wanted reassurance to see that the infant was seen quickly and their concerns were validated. And when you say validated, in that they were listened to. And then post initial assessment, information gathering, you wanted to know that guidelines were referenced and we were happy that clinicians were following guidelines or sort of framework to manage their infants. Um, some parents preferred verbal information, some preferred leaflets, but those who had leaflets type information said that actually was quite good because they could sit down and digest it because during that acute phase it can be very, very busy and they won't be able to absorb anything. But over time, they could sit down and look at something, whereas they couldn't remember everything verbally, clinician has said. And there's evidence saying that, that patients will retain, even we as clinicians will retain half of what we are told verbally about risk and treatment strategies, particularly if we are patients. So they really like the fact that if they were given time to reflect and self-search, and then shared decision making, opportunity to ask questions, and repetition of information, and creation of care plan. What they didn't like was when one clinician came in and said one thing, the other one came in and said a different thing, and that caused a lot of friction. Okay, but if you want to take anything away from this, is that I think this slide will explain it a bit more in that the evolution of shared decision making is not the same as the shared decision making when you're talking about adults or in non-acute situations where you have time, people are not too frazzled. in that when these infants come in, the parents are really, really stressed. The child is really, really unwell. So when it comes to decision making, they said that, um, at that point they trusted the clinician to make the decisions, which was important for the child. But as the child started getting better, then they wanted to take back that power and be more involved in decision to say, okay, fine, after 2 days of antibiotics, my child looks well. You know what? Actually, don't repeat the lumbar puncture. I think we can hold off on antibiotics. I think she looks well, or he looks well. So I think we can go home now. So, and that's the evolution of the shared decision making model that we kind of saw when we did the qualitative interviews from parents. But again, good communication was really key. Patient information leaflets were very good, in terms of allowing parents to digest the information, avoiding conflict between clinicians saying different things, and saying, picking the guideline as an institution or hospital and saying, look, we'll follow this guideline, and referencing that this is what we are following. We're following an international best practice, or we're following a hospital best practice guideline to manage your infant. So just to kind of summarize, we know that the best performing CDAs were the AAP and BSAC, and they were better than um, the Aronson and NICE in terms of sensitivity. But their specificity wasn't that great, but still they were able to identify 20% of low risk infants that could be sent, either LPs avoided, antibiotics avoided, and then they could be admitted for observation as well. We saw no difference in the AAP with CRP and PCT. However, AAP with PCT will cost more. Um, the other thing we found in this is that already practice is already changing, in that low risk scores could be admitted for observation or discharged. And then there's also the option to ambulate both low risk or high risk patients as well, depending on the resources your institution has to make that happen. And this would probably represent a better cost strategy than admission for all. Um, so that was our team, because that's me there, but I didn't do all of this by myself. It was all down to this whole group of people with me, and that's my supervisor, Tom Waterfield, Dr. Tom Waterfield, all this group of people together to try and bring out the FIDO study as you have seen it. Thank you. If you have any questions.
Amazing. Thank you, Dr. Amanda, for this nicely, very well presented and insightful presentation. So, any questions from the audience about the FIDO study? Because I have two questions from my side, actually. Okay, so my first question, how did you ensure uniform application of Decision 8 across 35 different sites? This is the first one. The
Mhm.
second one, how might this model be adapted to lower resources or non-UK settings, like in our setting?
No, that's an excellent question for both of them. So the main thing about the application when you apply clinical decision is like this, they're done as a post hoc.
Mm-hmm.
Okay. When we surveyed all the sites in UK and Ireland, about 90% were using NICE guidance, with only one site using BSAC. And
Nice.
then the remaining were just not using anything. So they were just kind of making it up as they go along. But that was very few, about maybe 5% of the sites. But majority were using NICE. So what we did is we collected all the data, all the information, their practice, practice variation and everything. And then we now apply the clinical decision is post hoc, right? To say that if you apply them, this is how they will perform within our cohort, as opposed to basically telling everybody to say, okay, register each clinical decision aid as you see the patients, because we knew that would be quite cumbersome, particularly as things are really busy. When it comes to clinical decision aids in a low risk setting, in the last maybe 5 to 10 years, there's been more like machine learning models, type of clinical decision aids. They're all fancy, they're all nice, but if you don't have electricity, if you don't have computers all around the place to use machine models and things like that, it doesn't make sense. So that's why I really preferred the clinical decision aids that were applied here, in that you had the Aronson, which didn't really require CRP, and most low resource settings are able to do a fluid ball count at least.
Mm-hmm.
Okay. And then that is the way to go. And then AAP, you can use CRP. If your setting can now use CRP, then you can now, go to things like AAP or the BSAC guidance. And I think that would be the way to go, but understanding the limitation. But one of the big things I would say is that before you use any CDA, I think it would be good just to look at your demographics and practice. Once you do that, then looking at the CDA and say, look, actually, this will fit with our population is actually very important. Because when my Spanish colleagues had looked at our data to say that we had 3.7% IBI rate, they were a bit alarmed in that that's it is within the literature span 1 to 4%, but they thought it would be lower. Like the American rates are around 2%.
Mhm.
So for us, it was important to do this study because we now understand what our population looks like. So when we're going to apply, we would look to something like the BSAC, which we already have, and the AAP.
Oh, okay. Seems interesting. However, I have noticed in the FIDO study that there is almost 14% of the infants has been discharged home. Is there any return visits within 72 hours after discharge? Have you noticed that?
Yeah, so about if I'm not mistaken, let me just see. So from that, about let me just get that figure. So I just get it and make sure it's accurate. Um,
And did they require admission after all,
yeah,
or
so about 6% we attended the emergency department within 7 days,
mm,
and of this, only seven were admitted, with two being diagnosed with a UTI.
okay, UTI.
Yeah,
Okay,
there was no IBI diagnosed in the return visit.
okay, great. And there's no mortalities as well.
No mortalities, no.
So is there any questions from the audience that you would like to ask Dr. Romana before we conclude? Okay, so we're having a question from Dr. Minder. Could the FIDO protocol be adapted for other populations, such as immune-compromised infants or those with complex medical needs?
So that is, Dr. Monter, that's a very amazing question. So when we did the FIDO study, we didn't limit, we didn't exclude those infants. We didn't exclude those infants. We included them in our analysis, and about 14% were said to have prior medical condition. That's 200, about 260 infants were said to have prior medical conditions. So when we applied it to the whole cohort, that was exactly as we applied it to the whole cohort. When we excluded them, because we did sensitivity analysis, we excluded them, and I think it was like 1,400, 1,600 and something, or 1,500 and something infants. The decision is still performed as well. Okay. However, the biggest thing with these infants are that they generally represent a much higher, like AAP, Spanish guidelines will always consider them as high risk and will always advise you to work them up efficiently. Okay, so I think that is the challenging bit with these infants. I wouldn't just if the guideline if the clinical decision tells me they're low risk, my opinion would be to what admit and observe because they're already at a high risk criteria. Okay, but you doing that has to be in an agreement with your own institution to say, okay, this is what we are going to do for high risk patients if they meet low risk criteria because it's not one person going off and just doing what they feel is right. It has to be your whole hospital group agrees this is what we're going to do. If they are AAP low risk, that's fine. That's great. That means we don't need to start trying to do an LP. And you can imagine some of these children trying to do an LP on them if they're already like high risk, immunocompromised. You don't want to introduce infection and say, fine, we won't do an LP. We'll hold off antibiotics. But if they spike again, if the vital signs deteriorate, antibiotics and LP. But it has to be at a hospital or departmental agreement for that to now happen.
Amazing. So anybody has any further questions? Okay, again, Dr. Minder is saying, is there a plan for follow-up studies to assess long-term outcomes or valid FIDO and delivering populations?
So We have looked at two populations, which I think is important. Long-term outcomes, I think, it was to follow up infants, 1,000 plus infants for long. You need a lot of funding to be able to do that. And I think that was one of the limitations. Obviously, we couldn't be funded to follow them up for 5 years to see how they did, maybe say when they were five. That would be great. It'd be really amazing. But that's an epidemiological study, and that would require a lot of resources to try and follow those infants up. So, but for diverse populations, we looked at those with who were flu, COVID, and RSV positive, okay, and looked at their rates of IBI. Now, the biggest thing we found was that if they were over 29 days of age, if they were 28 days of age, and they were positive for either COVID, flu, or RSV, that their risk of IBI was 0.7%. Okay. So what this is telling us is that maybe during those high flu or viral-like seasons, there may be a potential where if they're positive, you might limit things like, LPs, admission, or antibiotics because the likelihood of an IBI is low, about 0.7%. However, I think that study will need to be validated in other populations to see whether it is replicable. But the evidence is suggesting that that is likely the true rate of infection for those who are positive for those three viruses. The other ubiquitous viruses like enterovirus or parvovirus, like in terms of those who have viral swabs, nasal oropharyngeal swabs, we don't know because those ones sometimes can be commensal within the respiratory tract. Therefore, we can't really say whether the IBI risk could change or not. But for COVID, flu, and RSV, there's a potential there. The last population is those who have had an immunization.
Mm.
We had published a paper just recently as well, in that, and even BSAC is probably looking towards that direction, that if an infant has had immunization within 72 hours and they present within that 72 hours of immunization, particularly for the Bactero vaccine, right, which is meningitis vaccine, that the risk of IBI was like zero. However, they can have a UTI. So in those patients, at least if they come in within 72 hours of a vaccination, minimum a urine. If you want to do a blood test, you do a blood test. It didn't make a difference, but minimum a urine. And if the urine is negative, then there's nothing else you're going to do because it's likely due to the bacterial vaccine. So we have published the paper. So those are the two diverse populations that probably in the next couple of years will change practice in that if they're virus positive for those ones, I think it needs more evidence for that. But for the bacterial one, definitely there's a lot of evidence there to say within 72 hours, you shouldn't be doing like, doing all the blood tests and LPs and antibiotics for them.
Wonderful. Any further questions for Dr. Umana? Okay, so Dr. Minder again, are you planning to develop a real-time risk stratification tools or apps based on FIDO data to aid frontline physician, since the study showed some sort of a diverse practice across the centers?
So I think so when we looked at it, I don't think there's any point in us kind of recalibrating to develop our own risk score if BSAC and AAP CTA CRP is working effectively in our population. So I don't think we're going to go back and redo that. I think um, we have looked at our practice variation, and I think that's already shown. And I think the issue there is that there was no uniform guidance from NICE to say a lot of people didn't, how do I put it? So a lot of people were already adjusting their practice based on what they were seeing externally in the evidence. And I don't think until NICE changes, I think this is going to be the key thing. Until NICE changes, I don't think people outside, the whole UK is going to change their practice very significantly. Few centers that have very advanced practice, PEM training and all that kind of stuff will probably adopt things like BSAC or AAP because at the hospital level, they are okay and they can run it and they have the resources to do that. But most other institutions will just fall back to NICE because that's what they know. So we are not planning to do any kind of apps or things like that. So
Yeah, okay. Any further questions from the audience? So I think, Dr. Umana, we can collaborate together to do our FIDO Saudi study.
Yep.
Uh, Really amazing, to be honest, that we have to validate our tools, that if
Yeah.
it's fits to our population or not. This is really an amazing and insightful presentation, to be honest, that we would love to work together, inshallah, to get a great results.
Yeah.
So by this, I think we can conclude, Dr. Mana, and thank you so much for your insightful talk, insightful presentation, discussion. Thank you for all the audience who came to us and attended to this beneficial session. Thank you so much again, and see you inshallah soon. Bye.
Bye. Thank you. Bye.